Good evening, everyone, and on behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar, part 2 of the Geriatrics mini-series. We are thrilled today to have two great speakers, Kelly Ulen and Robert Accetta, who will both give some fantastic presentations for you tonight. Rob Accetta is the president and owner of River Care Consulting, LLC, a care strategy consulting business for post-acute rehabilitation, long-term assisted living, group home, and community care organizations. Rob holds executive leadership roles with nationally recognized healthcare organizations, local and corporately owned pharmacy concerns. He serves on the American Society of Consultant Pharmacists Board of Directors, representing the Northeast region, encompassing states from Maine, New Jersey, and the eastern half of Canada. He is a board-certified geriatric pharmacist and serves as a consultant and educator in a variety of roles. He is a member of the ASCP Connecticut and New York chapters, a member of AMDA, the Society for Post-Acute and Long-Term Care Medicine, and a contributor to Caring for the Ages, one of AMDA's member publications. He is a graduate of St. John's University, College of Pharmacy and Health Sciences in New York. Kelly Ulen is a PGY2 Geriatric Residency Program Director and serves as a Senior Clinical Pharmacy Specialist at Upstate University Hospital's Community Campus in Syracuse, New York. Kelly is the Secretary and Treasurer of the New York chapter of the American Society of Consultant Pharmacists, a past Secretary of the Central New York State Council for Health Systems Pharmacists, and a member of the American Society for Health Systems Pharmacists and the American Geriatric Society. She is on the Senior Care Pharmacist Editorial Review Board. She serves as a preceptor for Binghamton University School of Pharmacy and Pharmaceutical Sciences and Albany College of Pharmacy and Health Sciences for APPE students. She has worked in geriatrics for 9 years and is the founding director of the PGY2 Geriatric Residency Program at Upstate, which was recently accredited by ASHP for the maximum duration of 8 years. Kelly graduated from the Albany College of Pharmacy in 2012 with her Doctor of Pharmacy degree and is also a board-certified geriatric pharmacist. Before we get started, I'd like to share a few quick points. For those who have technological issues during the presentation, please use the chat option to communicate with the office, and every effort will be made to assist in a resolution. For those who have questions they would like to direct to the speaker, please use the question box or chat option. And the CE codes for this program will be provided at the end of the presentation. So I would like to now turn it over to Rob Accetta, who will give a presentation titled Psychotropic Drug Use in Long-Term Care Settings, It's Getting Another Look. Take it away, Rob.
Hey, good evening. Thank you, everyone. Nice to be here with you this evening and to have our presentation on this topic, psychotropic drug use in the long-term care setting and how it's getting another look. Bear with me for 1 second, get our slides moving. There's my information. You've already heard about me, so we'll move on to that. Next slide. Here's some learning objectives for this evening's talk. First, we want to provide some education on how to foster safer use of psychotropic drugs in all healthcare settings. Some learning about why these powerful medications, while helpful, are sometimes overprescribed. We will be reviewing the major side effects and adverse events associated with these drugs. We'll be identifying some of the clinical concerns associated with misuse and overprescribing. And finally, we'll be exploring what regulators are examining when they perform various surveys and inspections. So regarding the safer use of psychotropics, let's get into it. We want to help determine, and how can we determine to foster safer use of psychotropic drugs in all the healthcare settings? Well, not only are we as professionals and pharmacists interested, but of course it's a concern by representatives of government from all aspects. And we want to start talking today about the Office of Inspector General's report in 2011 and the use of antipsychotic drugs in nursing homes. And LTC, long-term care, is our focus for this evening's talk. So this Inspector General's report shines a light on the prevalence of prescribing of antipsychotic drugs in facilities, questions why medications are prescribed for folks with dementia and the inappropriate use of these drugs, and outlines the concerns over the consequences for the residents who are receiving these medications. And here's a slide shot to show the groundbreaking report from the OIG. And it really focused on folks who are participating in the Medicare drug benefits and Medicare Part A. So anyone in the short-term stay world would fall under Medicare Part A. And then for folks who are long-term residents, they would be focused under the Medicare Part D benefit. So Medicare is really the focus of this review. And the report is titled Medicare Atypical Antipsychotic Drug Claims for Elderly Nursing Home Residents. And so basically all of the data that was available from prescription drug claims was reviewed over a period of time. And this is the report that the Inspector General had for us. So on our next slide, kind of get into some of the nuts and bolts about it. For monitoring of psychotropic drug use in the nursing homes, this follow-up from that report was that these drugs are really front and center of concern. And there was a work plan that was addressed and announced in May of 2020. And here you can see really the highlight of the key takeaway here has to do with the OIG work and how CMS, the Centers for Medicare and Medicaid Services, took steps to address the risks of harm to nursing home residents. And so recently, CMS and researchers expressed the concerns that some nursing homes underreport antipsychotic drug use and may inaccurately report certain patient diagnoses in order to avoid appropriate CMS monitoring for use of these medications. And additionally, research on antipsychotic drug use has highlighted the need to closely monitor all psychotropic drug use to accurately oversee the drug use in nursing homes. So again, it's nursing home centric tonight, but I guess the main takeaway here is with the data, you're looking to identify patterns and trends of inappropriate use and inaccurate reporting and prescribing for these medications, and obviously to help reduce the risks of untoward effects and side effects. So the keystone to action started with the National Partnership in Dementia Care and the Partnership to Improve Dementia Care in Nursing Homes. That was many years ago, early part of the 2000s. And there's a follow-up report regarding antipsychotic medication use and the data in October 2020. And here basically it's kind of reviewing the statistics and the trends and where folks are with regard to delivering care for folks with dementia and how medications play a role and how we can help prevent side effects and adverse outcomes for folks. CMS in the center of this slide, I guess takeaway for this slide is that CMS is tracking the progress of the partnership by reviewing all the publicly reported measures. We're going to talk about measures in a moment. And the official measure of the partnership is the percentage of long-stay nursing home residents who receive an antipsychotic medication, with a couple of exceptions. And again, this is a nuance. The exceptions are those with a diagnosis of schizophrenia, Huntington's disease, or Tourette's syndrome. And so here we can take a look at the next slide, and we'll talk a little bit about where the statistics lie. And we look back in 2011 on the left-hand side of the slide, and we can see at that time when OIG did the initial study, we had approximately close to 25% of residents living in facilities and nursing homes using antipsychotic medications. These are the long-term residents. And as we see, after the project was initiated, you can see that red marker there in second quarter, or first and second quarter of 2012. You can see that the prevalence of the antipsychotic use begins to decline to where the numbers were that we last established significant numbers in 2020, second quarter of 2020. So of course, during COVID, here's one of the initiatives we're still looking at. COVID certainly took a highlight during that time, was more important, but nevertheless, we had to be looking at these medications and how the trends were falling. On our next slide, CMS divides the data and looks at it into different regions of the country. So you could look at this slide, and if you look on the left, you'd see the CMS region in particular, and where they were at the initial point of the survey and where they were in the second quarter of 2020. So nationally, if you look at the first line here in the first row, you can see that in 2011, in the fourth quarter, 24% of nursing home residents were receiving antipsychotics. Fast forward with all the initiatives we've had in trying to reduce these medications, we can see that the national average during COVID in the second quarter of 2020 was down to 14.1%. So that's a real significant change. And then it varies according to the region of the country that we're looking at. Here in New York, in the initial part of the study, we're at 20.1%. And at the second quarter of 2020, we were able to see a change of down to 10.7%, a huge change. We will say that that number has crept back up nationally over the last year or so. We're almost at a year since the second quarter of 2020. And certainly in the New York region, it's slightly crept up a bit. And if you're looking at statistics in the other regions, you can see the relevance for those areas as well. There is an OIG follow-up report. We were expecting the report to be presented in late 2021, but basically the highlights are that the OIG work found that the elderly nursing home residents who were prescribed antipsychotic drugs were at risk for harm. And so OIG presented the data to CMS. CMS is responsible for overseeing folks in nursing homes and facilities. And they took some of the OIG recommendations and then, of course, developed the new initiatives we're talking about this evening. So policymakers are still concerned about whether CMS has made sufficient progress in reducing the use of antipsychotic drugs. And so here's what the report from the OIG is to follow up on: the use of psychotropic drugs in general for nursing home residents, and that includes all categories. Citations and monetary penalties assessed to nursing homes when it comes to surveys and inspections regarding the use of these drugs, and then the presence of diagnoses that exclude nursing home residents from the measure. And so that's kind of like gaming the system, if you will. We saw that there were 3 particular diagnoses that were excluded from the CMS quality measures. And so the concern was facilities, prescribers were changing diagnosis or using an inappropriate diagnosis when these medications were being ordered. So now it's time for our first self-assessment question. Which government agency first raised concerns about the use of antipsychotic drugs in nursing homes? So is it A, the FDA? Is it B, CMS? Is it C, OIG? Or is it D, the FBI? I'll give you a beat. Think about it. Which agency have we been mostly talking about so far? It would be C, the OIG, Office of Inspector General, is the correct answer. So now I want to talk a little bit about psychotropics and quality measures. And of course, all of you on the call are familiar with the term quality measures. And there are different kinds of quality measures depending on the practice setting you're in. So if you're practicing in acute care and hospital settings, you have quality measures through the CMS folks. You also have quality measures through other accreditation bodies. In the long-term care setting, we have CMS quality measures for 2 kinds of folks: the short-term stay folks. So those are folks who transition over to us for a short period of time, usually anywhere from 14 to 21 days. They stay with us for rehab therapy to get stronger, or to receive IV medications or antibiotic therapy, or for wound care, or for a sepsis, following sepsis at the facility at the hospital, and they stay with us. Here are some of the short stay quality measures that we look and we are graded at. All of this information is available publicly, actually, on the CMS Nursing Home Compare website. But in general, I highlighted the one for us today for this talk, which is the percentage of short stay residents who received an antipsychotic medication for the first time while they were staying at our facility. And the next slide, we'll talk about the quality measures for the long stay residents, or the folks who are, long-term care residents. And you can see here on this slide, the number of types of different measures that are being looked at. I want to focus in particular about the 2 with regards to psychotropic drugs. The first one is the percentage of long stay residents who received an antipsychotic medication, and then the percentage of long stay residents who got an anti-anxiety or hypnotic medication. So you might want to know how is this data being reported? We have a tool in long-term care. It's called the Minimum Data Set, or MDS 3.0. And this is a document that the facilities have to complete on a regular basis. They have timeframes from admission throughout the person's stay, if they're here for short-term stay, and then also on a quarterly and annual basis, and also if there's a significant change. So all of these different times add up to the number of reporting instances that is made to CMS on behalf of the facility. And CMS takes the data and then will calculate the statistics. And that's what's being reported and compared in the various benchmarks we've talked about earlier. So we mentioned this earlier, and I think it's warrants reviewing again. Which diagnoses are excluded from quality measure calculations? And so we talked about the presence of diagnoses that exclude residents from CMS's measure of the use of antipsychotic drugs are schizophrenia, Huntington's chorea, and Tourette's syndrome. And generally speaking, there's recognition that if a person is on an antipsychotic medication for one of these three indications, it's not in the safest or best interest of the patient or the resident, as we call them in nursing homes, to reduce or discontinue these medications. These are, lifelong illnesses, and folks need to have these medications. However, as we mentioned, these three exclusions have been used in untoward ways to game the system for the reporting purposes. And so we have inaccurate reporting and diagnosis shifting. In the 2021 report that CMS has prepared, they're again looking at this particular occurrence, and they're looking to see how we can improve and reduce this from happening. And obviously, when we're not doing COVID inspections and infection control surveys during COVID, one of the ways would be to do the recertification surveys. We have also had special surveys in the last 3 to 4 years. We call them schizophrenia surveys, where they have a team of surveyors come out to our facility, look at the data that they've received from us, and then they go and look at every resident who has a diagnosis of schizophrenia, and they confirm through the history and the medical record that that is the actual medical diagnosis for medication use. Let's talk about the relevant CMS citation tags. We call them F tags in long-term care, and psychotropics. And these are from the requirements or conditions of participation. So these are regulations that facilities must follow to receive the federal funding, the Medicare and Medicaid dollars. And specifically around psychotropic meds, I wanted to highlight these particular 5 F tags. And as pharmacists, you probably be familiar with some of them. The first one on here is 605, dignity and chemical restraints, which refers to using medication against the resident's will or for convenience of the staff, and essentially, drugging them to keep them docile or to keep them from causing disturbances. It's really, certainly a really terrible situation when we've had folks receive these medications under those conditions. The next one would be activities. There could be potential issues if a person does not have an activity care plan and medications are being used where we've not tried non-pharmacological interventions. Our next one are the heart and soul of what consultant pharmacists do in long-term care, and also the provider pharmacies who provide medications to the residents of nursing facilities, which would be 756 medication regimen review, 757 unnecessary drugs, and that's tied in with the next one, 758 psychotropic medications. So I'm going to talk a little bit about these pharmacy-centric components, and I'm going to say that most of you realize or not that you're doing a lot of this work regardless of your practice setting, because you look at the medication orders and you have an analysis done through your education and also through the software you're using when you're receiving the orders in many of your systems-based EMR, electronic health records. But let's talk about this one, the drug regimen review. So the requirement is in a nursing home that the drug regimen for a resident has to be reviewed at least once a month by a licensed pharmacist, and it must include a review of the resident's medical chart. So that's not just a list of orders, it's a looking through the chart, and that includes all consults, all other outside appointments that have been made, any other progress notes, and it includes things like the hospital discharge documents which are critical during med reconciliation and transitions of care. And the pharmacist's duty is to report any irregularities to the attending physician and the facility's medical director and director of nursing. And not only do you report it as a pharmacist, but these reports carry weight. They have to be acted on. So this is in the code. It's not just making a suggestion. It's you need the prescriber, the attending physician, or the medical director to act on them. And here's some examples of irregularities. Essentially they are include but not limited to any drug that meets the criteria set forth in a paragraph that we're going to talk about in a second here. So the pharmacist review, when the pharmacist is doing that medication regimen review, they consider obviously all of the different things we've just talked about. And then here on these next several slides in the blue font, we're taking this actually from the guidance to the inspectors, the guidance to surveyors, and what the layperson surveyor, who could be a nurse, a professional, it could be a dietitian, it could be a social worker, it could be a pharmacist, although we don't have many pharmacists on these survey teams nowadays, but this is the information that they're trained on what to look for. So they're looking at the various components, such as whether the physician and staff have documented progress towards or decline from or maintenance of the resident's goals for the med therapy. So we get into the nitty-gritty of medication therapy, what the meds are being used for, and whether the physician and the staff have documented any attempts for gradual dose reduction or added any non-pharmacological approaches in an effort to reduce or discontinue a medication. Very important. GDR is very important. Here on this slide, these are very much concerns where you would have to dig into the chart. And as a pharmacist, you may be familiar with side effects from medications. And so you might think, well, a person is receiving Accetta, they have Alzheimer's disease. And so that's a good thing because they're on a medication that's going to help alleviate Alzheimer's disease. Could be mild to moderate of nature. But Accetta comes with side effects. Some of the side effects include weight loss and anorexia. So pharmacists, are you reviewing and are you making any recommendations regarding that medication? And if you observe weight loss on the resident, are you telling the physician to look at whether or not this medication is causing the side effect? And you can see here on the slide, other very typical things that could happen when medications are being prescribed, such as changes in bowel function. Think about using opioids, confusion, cognitive decline, worsening of dementia, delirium, dehydration, use of diuretics, excessive dehydration, sedation, insomnia, the timing of certain medications, falls or dizziness. Clearly, these are all concerns that we have when we're talking about the folks who live in long-term care. The next piece here we'll talk about is the unnecessary drug tag. And generally, it's each resident's drug regimen must be free from unnecessary drugs. Easily stated, right? An unnecessary drug is any drug when used under the following conditions. So it's in excessive doses, and then they give a description of what the excessive dose is, and including duplication of therapy. So where you see, an example might be we have oral inhalers to treat asthma or COPD, and we have Brio. I'm just thinking of a few brand items, not to be specific of a brand, but some of the inhalers, Brio, Symbicort, combinations of products that have duplicative drugs. Just one example that comes to mind. Drugs used for excessive duration. And here it's again to help determine why the person is still getting. An example might be under antimicrobial stewardship. Are we using antibiotics for long periods of time? Are we using medications unnecessarily where there should have been a stop order in place? A couple of examples there. Here's again some concerns. Failure to review the underlying cause that has been resolved could lead to an excessive duration. So think about if a person has delirium, they're sent out to the hospital, they come back to the facility, they were treated in the hospital for delirium with an antipsychotic medication, totally appropriate in the hospital setting, being monitored closely. They come back to the facility on that medication, and well, we find that they're still getting that antipsychotic, and if the pharmacist is not asking to have that medication have a gradual dose reduction or stopped, that's an example of excessive duration. Delirium has resolved and they're still taking that medication. Here's another concern, drugs not having adequate monitoring. You can see in the slide there's various types of monitoring. I think in this case, it's obviously side effects from medications and also labs. Labs are critical for narrow therapeutic index drugs, and we'd also be looking at monitoring for toxicity for drugs that have that narrow therapeutic index. And just in general, if we're using diuretics, we'd be looking for basic metabolic panel. If we're using statins, we would be looking to see what the liver function is. We're going to be looking for, obviously, for creatinine clearance, or more likely for the estimated GFR for most of our folks, and that helps us with the dosing of medications. Another concern, without using medications without the indications or adequate indications for use, and this goes to, medications being prescribed in their health record and someone using a drop-down menu and clicking and perhaps clicking the wrong indication for use. So again, pharmacist has to look at those medications and make sure that the orders make sense and that the indication for use is accurate. And so if not, we would need to make that recommendation to have the medication reassessed. And another here is in the presence of any adverse consequences, which indicates that the dose should be reduced or discontinued. So, again, it's looking at the highest risks and the highest risk categories of medications. We know what those are: blood thinners, insulins, some anti-diabetic regimens, opioids. These products, clearly put residents at risk. And so, are we looking for the adverse consequences? What do we see as pharmacists? Well, we're going to look at medication administration records. We're going to look at things such as blood glucose monitoring results, blood pressure recordings. We're going to look at lab values. I think, depending on your setting, you may see this also in your integrated EHR, where you're getting a prompt about a lab that came back, and has the prescriber, has the facility staff been alerted to it? What you as a pharmacist should be doing, of course, is monitoring for those and connecting with that person and making sure they're aware. So again, any combinations of those reasons, the facility would be at risk for having an unnecessary drug citation, and that could be for psychotropics or any of the other medications a person is taking. Now it's time for our second self-assessment question. And so here we are. An example of an unnecessary drug includes A, a psychotropic prescribed without an appropriate reason; B, a medication ordered which sedates the resident and prevents them from getting up during the day; C, a drug ordered because a nurse wants the resident to be quiet at bedtime; or D, all of the above. I'll give you a beat. I think this is a pretty self-explanatory question with the answer, and the answer is going to be D, all of the above are reasons where we would say a medication is unnecessary during our reviews. The psychotropics tag, it's pretty extensive. I'm going to spend some time on it, but here I wanted you to see and have this when you receive your slide deck. This is really coming directly out of the conditions of participation and the regulations. And it talks to residents having a comprehensive assessment and how in long-term care, we must make sure that residents who have not received or used psychotropic drugs are not given them. So we shouldn't be starting them unless the medication is necessary to treat a specific diagnosed condition and documented in the clinical record. And then there are parameters here for residents to receive the GDR, gradual dose reductions, and other interventions. So the other interventions are the non-pharm interventions. So including your therapeutic activities folks who provide activities for the residents, other modalities, besides medications that are offered, and so on. Folks need to have a GDR, gradual dose reduction, unless it's been determined to be clinically contraindicated in an effort to discontinue these medications. And then there's more directives regarding the use of a PRN medication, that an antipsychotic should not be prescribed for more than 14 days as a PRN, and the prescriber has to reassess the resident in person when that occurs. And there's, again, some directives for the use of any PRN psychotropic medication where these medications have to be reviewed. So pharmacists are, front and center when it comes to creating a plan for the facility. So it's not just the medical director, it's not just the prescriber. We're pharmacists, we're looking at, yes, we're drilling down to the individual patient, but we also have to have a 30,000-foot plan on how to help the facility make sure they're in compliance with this regulation. And of course, it's good medical practice for residents not to receive medications that they don't need, and specifically these drugs. So here, the next slide talks to the psychotropic drug definition: antipsychotic, antidepressant, anti-anxiety, and hypnotic. Makes sense. And here we talked about this earlier. And so again, for the slide information, I wanted you to have this information. The requirement is especially important when prescribing psychotropic meds, which are defined in the guidance in those particular categories. And it's really assessed on a regular basis. Here we talked about that part where they should not be receiving psychotropic drugs unless the medication is necessary to treat a specific condition. And use of psychotropic medications other than antipsychotics should not increase when the efforts to decrease antipsychotic drugs are being implemented, unless other types of psychotropic drugs are clinically indicated. So what does that mean? Don't try to switch an antipsychotic to another class of a psychotropic drug because you're reducing the antipsychotic. The goal is to have folks on the lowest dose of a medication they need, or not to have them on them at all. But do not engage in drug swapping, category swapping, removing antipsychotics to do better with your statistics and quality measures, and then adding a host of other psychotropic medications. Counterintuitive. Here we talk about the regulations and addressing the use of tapering, or trying to do the gradual dose reduction, and what the requirements are. And it's very specific. Within the first year of a long-term care resident stay, they have to have an initiation of a GDR in 2 separate quarters with a month in between. Here, again, more information regarding psychotropics. I think it's important, again, to kind of highlight these particular teaching guidances that are provided to the surveyors. And we know this to be good practice for any individual who's receiving a psychotropic med to treat a disorder other than expressions or indications of distress related to dementia. So example, schizophrenia, bipolar disorder, depression with psychotic features, or another medical condition other than dementia, which can cause psychosis. The GDR may be considered clinically contraindicated. And so the highlight here is the word dementia or dementia-related psychosis. And we need to focus on using antipsychotics for folks that have dementia-related psychosis. We know that there's FDA black box warnings for these medications when it comes to being used and prescribed for these indications. There is no FDA-approved indication for an antipsychotic for a person with dementia-related psychosis. Here we talk again about the code, the regulation about receiving PRNs, and we should not be using PRNs really unless that medication is necessary to treat a specific diagnosed condition that's documented in the clinical record. And that's a key. We're looking back at medications being started when the person is admitted from acute care to the long-term care, short-term stay facility, and treating let's say the delirium at the hospital with a PRN quetiapine or a PRN risperidone order when they're admitted, started at the hospital, carried over to the facility, but we have to make sure that that medication is not being used. They could be used in appropriate care when a person is on a maintenance therapy for an appropriate medication diagnosis. So it could be used to titrate up or down, but again, it's subject to the limit of the 14 days and the review of the prescriber. And here's the highlight again: PRN orders for psychotropic drugs limited to 14 days. And the physician or the prescriber can order the medication that's not an antipsychotic, psychotropic drug as a PRN to be extended beyond 14 days if they document well in the notes. So in general, the game plan would be, let's not have PRNs to be ordered for more than 14 days in any case for any psychotropic drug. And I think, again, talking about the 30,000-foot plan, that's what we as consultants would recommend in general. Avoid using these PRNs as much as possible. Here again, we highlight for your reference the PRN orders for antipsychotics and limits to 14 days, and that the prescriber must evaluate the resident in person, directly examining the resident to determine whether or not they need this medication. So highlighting again, avoiding the use of inappropriate prescribing of psychotropics and antipsychotics. Okay, self-assessment question number 3. Long-term care facilities are required to attempt GDRs of psychotropics except for residents with a diagnosis of A, psychosis, B, insomnia, C, depression, D, schizophrenia, or E, general anxiety disorder. And I know you will get this one correct. I'm going to give you a beat to think about it. And the correct answer is D, schizophrenia. We are not required to attempt GDRs for these folks if they have an appropriate diagnosis of schizophrenia, but we are required for all of the other indications mentioned in this question. Training on drug management. So again, pharmacists, we know a lot, we have a lot of information is available in the palm of our hand, right? Dr. Google, and we look at our various apps, but we have lots of paper training or education that's provided to surveyors who are coming in looking at these medications. And so again, I want to say that this is not just in long-term care, but this is any practice setting you're in, whether it's in the hospital, acute care, whether it's in community-based care you may practice in. We have concerns about side effects, anticholinergic side effects. It has been taking front and center. It's a hot button concern lately. So it's an effective medications. And here there's a really good definition for the surveyor and the side effects that they should be looking for and document that you would see in the progress notes in the EHR. Dry mouth, blurry vision, tachycardia, and so on, urinary retention, all of these side effects. So the anticholinergic side effect burden and the anticholinergic cascade, all terms you probably have heard recently, and certainly front and center for us when we're doing monitoring when it comes to the use of these psychotropic drugs. And there you see the list of types of medications that produce or can produce anticholinergic side effects. Front and center, antidepressants, antipsychotics. So I want to give you some pearls as we transition to the next part of the talk. The pearls related to psychotropic medication use and the risks associated with use of psychotropics, both antipsychotics, and all other psychotropic drugs at any dose with any regimen. First of all, the FDA black box warning on antipsychotics for atypical and typical antipsychotics and for dementia-related psychosis. So we talked about that. Sedation, concerns about the quality of life for folks receiving these medications, participation in ability to take part in activities during the daytime, if they're in the facility for a rehab program, that they're not over-medicated and they can participate in their rehab sessions. Falls, number one concern for folks who receive any medication that alters brain status, causes sedation. So falls were measured heavily, falls with head injuries even more so. And several categories of these medications are contributors, as we know. And then, you know, again, using these medications, we have certain parameters we should be looking at, such as the cardiac function and rhythm abnormalities, which require EKG monitoring. So some classes of drugs like the SSRIs, certainly we have to look at QTC prolongation and combinations of drugs as well. So drug categories being utilized, causing that potential risk. Some more risks regarding psychotropic drugs include prescribers. Prescribers who aren't confident or knowledgeable about the use of these drugs and the consequences of them. So you think, well, that's a no-brainer. They're ordering the medication. They should know about the side effects. But really, in practice, it's not so. We as pharmacists need to have those talks with prescribers when they're ordering these drugs and kind of guide them gently on using products that, depending on the resident's comorbid conditions, would be safer to use. Using them, in opportunities to reduce or take the person off of that medication. Very, very important. Drug interactions, additive effects, and synergistic effects of different combinations of drugs, different categories. Come to mind for me would be the use of benzodiazepines, psychotropic drug, and opioids. Opioids have quality measures now where we're looking at that combination and the increased risk for opioid or substance use disorder, and also for fall risks. The use of drugs from multiple classes, cocktail fashion, adding a drug and having 2 or 3 different psychotropic drugs instead of taking one medication and coming up with the best dose of that medication, maximizing it and getting the benefit, trying to avoid cocktails if possible. And then, of course, the prescribing cascade. I think many of us have seen examples of this, and maybe we're aware of them. Sometimes we may not be if we're not looking at the entire profile, but typically an example is not necessarily related to psychotropic drugs, but let's say a person is receiving calcium channel blocker, amlodipine, and they're having some type of fluid retention. Next thing you know, they're getting a dose of Lasix. And so they add Lasix in the cascade, and a couple of days later, they're dehydrated because of the Lasix. There's a cascade that happens, the person acts out, and they get a medication added, which is a psychotropic drug to treat the symptoms that are related to all of these other concerns. So psychoactive meds and the categories that are considered psychoactive, here's, again, a pearl just based on typical utilization in facilities and long-term care and other care settings. They are antipsychotics, sedative hypnotics, anxiolytics, antidepressants, and we call miscellaneous drugs that are used off-label. We'll talk about that. So here, antipsychotics, again, the most powerful drugs in their ability to change chemical imbalances in the brain. We're not doing a pharmacology session tonight. We're just kind of giving this overview. They're used to foster the improvement of mental health and for the appropriate medical indication or diagnosis. We have severe risks that are associated with continued use of these drugs in the elderly. We know antipsychotics especially have that risk associated with cardiac concerns and death. Excuse me. So these drugs should only be prescribed for a specific medical indication, and here they are. Psychosis, delusional disorders, schizophrenia, bipolar. They should not be ordered for the treatment of dementia. And in our setting, again, we talked about the necessary GDR attempts and the frequency. Here's, again, common antipsychotics prescribed. I'm sure you're all familiar with these names. These are the ones that we see most often in the facility. I think the one that I see with a lot of concern these days is clozapine with the REMS recent change and the monitoring regarding the use of that medication. Lithium is another drug we see, although not that often. Narrow therapeutic index. We have to look closely at dietary intake of sodium to make sure that there's no issue. But again, looking at the side effects, sedation, movement disorders, hypotension, tremor, shuffling gait, excess salivation, increased risk for falls, and increased risk for death in folks with dementia. Sedative hypnotics, our next group, the used for insomnia. They should only be used to treat symptoms of insomnia that can't be relieved with other modalities. So medication should not be the first go-to. We, of course, receive folks who are taking these medications forever. And so we have to, again, try to get them off these medications if we can, or reduce the medication dose. Try to discourage long-term use, have them used for brief periods only, 7 days to 10 days is appropriate. We see an increased use of melatonin as an alternative, which is course, not a drug, so it's not considered a hypnotic, although it does help with the sleep cycle. It may be helpful, but there's no evidence, not sufficient evidence for using it in dementia care. Here's some commonly prescribed sedative hypnotics that we see in long-term care facilities. Zolpidem, number one. Temazepam, not so much anymore. Lorazepam could be used to treat anxiety, and they could also be using it at bedtime for sleep. And so we know what the side effects are. With the benzos, of course, it's the risk for falls. And in general, using these medications causes daytime sedation in many cases. The anxiolytics, they're prescribed obviously to treat anxiety. They're used to treat symptoms which cause the resident distress. That's the key. They shouldn't be on them because they had an incident that happened 17 years ago, and they're still taking it because that's what they used 17 years ago. We need to make sure that they're not having an issue, and if they're not, we should have that medication reduced or discontinued. If they need to be on the medication, we need to have documentation that the drugs improve their functional status, and they also have to be evaluated as part of the GDR requirement. Some examples of commonly prescribed and anxiolytics in facilities would be, again, those benzodiazepines. Some of them may be used for other indications, such as for seizure disorder, thinking of clonazepam. Nevertheless, these are the drugs that we see often, and we're concerned about the sedation and the dependence that occurs when using these medications, and as a class, the high risk for falls. Antidepressants, high prescribing of these medications. Medications are used to treat depression, which is a chronic or enduring medical condition. However, we do know that some cases the depression can resolve and the medication can be reduced or stopped. And so this is part of that initiative to have gradual dose reduction assessments for any psychotropic drug. And so we go back to all of these drugs should be assessed periodically to determine their effectiveness. And these drugs are subject to the GDR requirement for assessing and for tapering. Common examples, the SSRIs stand out in this class. We have a couple of older drugs that we'll see, such as nortriptyline, amitriptyline. They could be used not only for depression, but for neuropathic pain or pain management. Trazodone, mirtazapine, these drugs could be used as well. Trazodone for insomnia, mirtazapine at low doses for appetite stimulation or anorexia. Off-label prescribing, or the miscellaneous categories here, we talk about drugs that could be used to treat symptoms associated with a psychiatric diagnosis that could be prescribed off-label. Commonly prescribed in facilities, valproic acid, gabapentin, oxcarbazepine, and lamotrigine. So many of these drugs have primary FDA-approved indications. They're used off-label in facilities. These drugs are prime candidates for that concern we talked about of switching a medication, an antipsychotic, and placing somebody on valproic acid. In fact, there was an article not too long ago in the New York Times that specifically talked about antipsychotic medications and then switching from that category of medication to drugs such as valproic acid that was being underreported and under-scrutinized through CMS reviews and guidance. So again, these medications are helpful. They're not first-line drugs, but you have to make sure that we're using them appropriately and trying to get these medications reduced when possible. And of course, monitoring with certain lab tests that would be appropriate, such as for valproic acid, oxcarbazepine, and lamotrigine. So the interdisciplinary team and person-centered care. Again, I want you to think about this while we talk about it. What do you do as pharmacists? You're a part of that team. You may be sitting at the computer processing an order. You may be a consultant pharmacist looking at a chart. You may be interacting with an intern or resident at your hospital. But this is certainly what you're doing as you're processing, using your education, these medications as they're being prescribed. So in a facility, we have the team approach to manage medications, and it includes, of course, the individual care plan, a medical care, and assessment on a monthly basis. The non-pharmacological interventions are the key to be attempted and to be monitored and documented. The use of specially designed template notes is very helpful, and your team can create those notes. I have a couple of samples to share. The monthly review of medications by the pharmacist in your facility. It could be done based upon the minimum requirement, which is a monthly review. It could be more often. It could be targeted to look at, again, looking at psychotropic drugs and having, a psych rounds. We do that in some facilities where we actually go around and sit with the team and look at only folks who are receiving psychotropics. And so these are the disciplines that participate. It's the physician, the pharmacist, the nurse practitioner or nurse, social services, and activities folks. All of these folks have relevant comments to make regarding the care given the residents, and it helps us all as a team make decisions on how we can use that information to do a GDR, dose reduction. Here's a sample template note. You'll see this in your slides, in your handout when you receive it. Here's how to capture interventions, and an example that we use in some of our facilities for GDR. And it's basically kind of recapitulating what I just talked about. It's mentioning the team, the folks who sat in and discussed the residents' care, and then what we did about it. And this actually goes into the electronic health record of the resident so that it's available for disclosure and discovery by a surveyor. And this goes a long way to show that the facility has made the attempt to do the GDR. Here we have an intervention that the pharmacist makes when there has been a fall. And so again, looking at combinations of drugs, antihypertensives, psychotropic drugs, all of these medications put the resident at risk for falls. And so here the pharmacist in this facility is called, notified when there's been a fall. The pharmacist does a thorough targeted review of the medications that the person's receiving, looks at other factors such as monitoring, labs, and so on, and then makes the determination based on those findings of recommendations. So we have a template here recommending blood pressure monitoring, or if the person is at risk for hypoglycemia and has had a fall, it will make that suggestion here. But particularly around the fall, we're looking to capture opportunities to intervene and mitigate combinations of medications. We focus heavily on those who are receiving psychotropic drugs. Here's a sample template note. It's 2 slides. So we give you the first part here. We called it an incident-based behavioral health progress note. And so this note is available, and you're going to see it has lots of data that could be collected on an incident that occurred with the resident. And what's, really the purpose of having this is twofold. It's documenting, capturing the information that might otherwise go undocumented, and also anybody who has access to the medical record and the EHR, any of those disciplines we've talked about, is encouraged to use this progress note template to write of an incident and how it was handled and what was reported to the prescriber and the medical team. It's very helpful, again, in helping us decide whether or not medications can be changed, reduced, have gradual reductions, and so on. So here's the other part of that slide, and we talk about the non-pharmacological interventions when a person has an outburst, and you can see some of these interventions here. Reflections on a person-centered care for anyone receiving psychotropic meds. So again, it's just to go back and reflect, things to ask yourself. What's my role as a provider of care to the residents? What do I bring to the table? Not just dispensing a drug, but it's more about the analysis and using our education and our training. How well will I be communicating with the residents who have capacity, and their families, and other members of the care team? So as I see an order for a medication that, I'm familiar with the guidance, and I also know about side effects, am I talking with that prescriber? Am I discussing it with the family? Bringing these things to light, having conversations and shared decision-making about the attempt to reduce medications. It goes a long way when we're trying to accomplish that goal of fewer medications and the least necessary dose of a drug. Be aware of the medications for each resident. Of course, discuss these with the medical team and the prescribers. and just advocate for using only the lowest dose necessary, or even none if it's possible. And so that's the end of the discussion from my side. If you have any questions, there's my information for an email. I'd be happy to entertain any questions through this email or through the office. And I am going to say thank you. At the end here, I have an appendix with additional guidance to surveyors and the F tags. I'll just quickly show them to you. We mentioned the 605 dignity to be free of chemical restraint. So there's guidance here on use of these medications in those instances. Also, we talk about activities and behavioral interventions and non-pharmacological approaches. So I have that guidance for you there. And now I'm going to stop sharing my screen and take a breath.
Thank you so much for that presentation, Rob. We do have one question that was posted in the chat and a few more coming in now. So the first one is screening for a lipid panel and metabolic syndrome required for residents on antipsychotics long-term?
So the recommendation that we have for screening when it comes to using antipsychotics is centralized mostly around diabetes care. And so we would recommend an A1C be done on a routine basis, and that routine could be, again, depending on the resident's comorbid conditions, but antipsychotics are known to increase the risk for diabetes. We would say an A1C every 4 to 6 months might be appropriate. Yes, these drugs cause dyslipidemias, and again, based on the resident's own criteria and their comorbid conditions, a good rule of thumb might be, again, every 4 to 6 months for a I would say a liver panel. Some physicians, prescribers may say once a year is enough. So I would definitely say at minimum once a year would be recommended.
Great. One more question that came in the chat is, do you have issues when these medications are crushed?
There's a good question there when it comes to crushing of medications. We have certain folks that have dementia who have difficulty taking medications because because of dementia, and they're not willing to swallow medications. And so the nurses may have to crush them. We also have folks who have dysphagia and have been evaluated by, let's say, a speech language pathologist, and note that these folks are at risk for swallowing concerns or choking when they're trying to swallow meds. In those cases, we as pharmacists would look at some clues. Obviously, we're going to look in the progress notes to see if those indications and diagnoses are present. And if so, we would ask that the medications it would be in order to have medications crushed. And in some cases, they can be mixed with fluids, or they can be mixed with applesauce to facilitate the administration. And then in other cases, we would have these medications change when they cannot be crushed, and we will bring that to the attention of the prescriber.
Very good. And that was the last question that we had in the chat. If anyone has any additional questions for Rob, you can direct them to the office and we will send them his way. At this time, I would like to bring up the next presenter, Dr. Ulen, who will be presenting frontotemporal degeneration, a cruel and often misdiagnosed, mistreated form of dementia. Take it away, Dr. Ulen.
Thank you so much. All right, thanks everybody for calling in tonight. See here. Okay, this is a little bit about me if you're interested. And my disclosure, we're going to be talking about some medications that are used off-label tonight. These are the learning objectives for your review. And then we'll get into it. So, sorry here, my mouse is a little sensitive. This is my mom. This photo was taken about 4.5 years ago now, and my mom was started displaying symptoms of FTD about 2 years ago, and now she is actually in a nursing home. So this is going to give you a little bit of what's to come for tonight, but you can tell it can be a very, very aggressive form of dementia, and unfortunately affects young people. So let's talk a little bit about frontotemporal dementia. And also, I forgot to mention, if anybody on the call tonight, I know there's a couple of you who were at the annual meeting for ASCP and heard me give this talk. I've added a new section in the middle. It's a new report that came out that's really interesting, that gives us some insight into caregivers and patients' perspective of living with FTD. So there'll be something a little in there for you as well. So FTD has a couple of different names. It's frequently referred to as frontotemporal degeneration. That is the proper name. It's also called frontotemporal dementia, and it used to be called Pick's disease after Arnold Pick, who was the scientist that first found these areas of atrophy in the brain that now we know is frontotemporal degeneration. So going forward, just to save me some words, I'm going to refer to it as FTD. So FTD represents a group of brain disorders caused by degeneration of the frontal and temporal lobes of the brain. And as we get into it a little bit more, you're going to see there's actually different variants underneath the FTD umbrella. And it's really all about where in the area of the brain are we first starting to see atrophy. But a hallmark of FTD, regardless of what kind it is a gradual progressive decline in behavior and or language. And it also can cause a decline in motor function. So we'll get more into that as we go forward. Let's talk about the prevalence of FTD first. There's about 60,000 cases reported in the US. It has an equal distribution of gender. It is frequently familial and hereditary. Non-genetic risk factors have not yet quite been identified. There is some early data to show that it may be related to traumatic brain injuries. However, it's still a little too early to conclusively say that. The survival is similar to Alzheimer's disease. Now, it's important to note, and we're going to talk about this when we get to the misdiagnosis section, but I think 60,000 cases is actually a gross underestimation of how often actually FTD is occurring in the US. Sorry, this mouse is so touchy. So FTD, it's the most common cause of early onset dementia. The mean age of onset is 60 years young. So when you think about that, and we'll get into it, but we're going to have patients who could be as young as in their 20s. And as late as about 65, we've seen it diagnosed in patients. We'll talk about my mom later, but I was really fortunate. She didn't start displaying symptoms of FTD until she was 63. Life expectancy is about 7.5 years, but it's really important to note that that life expectancy is from the average survival time from first symptoms. And since it takes, on average, most patients about 4 years to get the correct diagnosis, it's important to just keep that in mind. And the reason why we so often see it misdiagnosed is because it mimics many psych disorders. I wanted to just talk briefly, I wanted to dedicate one slide to this because I feel like most people are really comfortable with Alzheimer's dementia. It is the most common form of dementia. I wanted to compare that to FTD to really highlight what FTD is. So we know that Alzheimer's dementia is the most common dementia that we have in older people, whereas FTD is the most common dementia in younger people. Alzheimer's, typically we see begins with memory loss, and this is key here with FTD. FTD usually begins with behavior or language disorder. And again, that's depending on where in the brain we're first having the atrophy. For Alzheimer's, the odds of having Alzheimer's disease increase as you get older, where the odds of having FTD actually decrease as you get older. And here is a really great picture that's showing the atrophy in the frontal and temporal lobes and comparing that with Alzheimer's. So you can really see it's a marked difference. So when we think about the frontal lobe functions, motor function, the ability to walk, social and sexual behavior, problem solving, this is a really, really big one, is impulse control. And then we end up having to try to treat patients, oftentimes pharmacologically, because it's really challenging. In the temporal lobe functions, we have visual memory, language comprehension. So eventually FTD can rob patients of their ability to speak. It also controls our emotion association. So we'll see a lot of patients with FTD who have apathy or an inability to pick up on any type of social cues that their behavior is inappropriate, as well as the formation of language. So this is a slide just for your reference, and these slides will be available up on the NYSCHP website to probably in the near future. So you can reference this, but I just wanted to put this up here so we have a better understanding of, okay, the frontal and temporal lobes are affected in this type of dementia, and what does that mean? So we'll get more into that here as we go forward. So the clinical presentation. Depression is a commonly seen symptom in all neurodegenerative dementias and should be treated. So this is the first thing you want to look for. If you're doing a chart review, or if you are seeing a patient that potentially may have FTD or any type of FTD, we need to be assessing them for depression and making sure that we're treating them appropriately. Cardinal features of PPA. So now we're going to start to talk about these variants. And for now, we're just going to talk about the two most common variants of FTD. So again, if you think of FTD as an umbrella, we have underneath that umbrella, primary progressive aphasia, which is where we're going to see patients who are having difficulty with understanding words, problems with reading and with writing. Now, also under that umbrella, we have the behavioral variant of FTD, and this is the most common variant. In this form, we're going to see disinhibition, apathy, lack of empathy, compulsive behavior, and even altered eating habits. So under our FTD umbrella, it's a cluster of complex disorders. We have the progressive behavior with personality change. So that's where we see the behavioral variant of FTD. This is the most common. We have the progressive language change with the primary progressive aphasia, and then there are subtypes under that. And then we have the progressive motor function and movement change. And this is where we see corticobasal syndrome, progressive supranuclear palsy, and we actually have an FTD with ALS combination, which is just a terrible card to draw for those patients. And we're going to focus again on behavioral variant and primary progressive because these are the most common. The motor function movement changes typically are not seen as often. So primary progressive aphasia, it's characterized predominantly by the gradual loss of the ability to speak, read, write, and understand what others are saying. So you can imagine how frustrating this must be for our patients. The diagnosis criteria, there are three things. We see a gradual impairment in language, not just their speech. We see the language problem is initially the only impairment. So it starts with language first. The underlying cause is a neurodegenerative disease. Primary progressive aphasia, so we've talked about it's the deterioration in ability to produce speech, understand words, recognize objects. And so symptoms we see with that would be hesitant, effortful speech, comprehension of speech may be preserved in the early stages. So sometimes these patients are able to compensate for a little bit, but eventually it's markedly noticeable. And in these patients, we typically see that it lacks the features of the behavioral variant of FTD. It's important to note that, again, we're going to diagnose it based on the symptoms that we first see, but eventually, if the patient lives long enough with primary progressive aphasia, they will develop behavioral variant symptoms as well once that area of the brain is also affected. And so in our patients in postmortem analysis of the brain, they found a tau protein pathology. The behavioral variant of FTD, again, being the most common variant, this is the variant that my mom has. We see changes in the personality, emotions, and or behaviors. A hallmark of this, which is really interesting, kind of a pearl to keep in the back of your mind as you're on rounds with the team and they happen to mention this, is a hyperoral craving. So these patients are really tend to typically be really obsessed with sweets. So we're talking a sweet tooth that is above and beyond. So I can tell you, in my mom, she had diabetes since she was in her 30s. So she was always very cognizant and cautious of eating sweets. And once she had FTD, she would want to go to the drive-thru to get an ice cream sundae every day, all the time. And she could have just gotten home from it and would want another one. So it's just this really chronic craving of sweets that's a hallmark of the behavioral variant. We see disinhibited actions, so making inappropriate comments. So this, you'll hear a lot of stories of patients who have behavioral variant FTD that end up getting fired from their job. So they could have been a stellar employee for 20 plus years. And all of a sudden, it's like they're a different person. They're acting inappropriately. They lack any social cues or apathy. They are completely unaware of the impact of what they're doing is on others, as well as impaired decision-making. And this is associated with tau or the Alzheimer's dementia pathology in postmortem review. So this is a really fascinating study. Woolley et al. Came out with this about 10 years ago now, but this was a systematic, retrospective, blinded chart review of patients with a neurodegenerative diagnosis. So we see on the left, we have behavioral variant that with an N of about 70 patients. Alzheimer's, about 65, semantic dementia, about 41, progressive non-fluent aphasia, about 17 patients, corticobasal degeneration, about 25, and progressive supranuclear palsy, about 15. And then in the very end, we have ALS. So 28.2% of patients with a neurodegenerative disease received a prior psychiatric diagnosis. So this is why we're so often seeing misdiagnosis in these patients. Unfortunately, how they present is often considered to be depression, which was the most common psychiatric diagnosis of all the groups. And then in particular, on the left-hand column, you'll see behavioral variant FTD patients received a prior psychiatric diagnosis significantly more often, 52.2% more often than patients with Alzheimer's dementia, who were given that diagnosis about 23% of the time. And they were more likely to receive a diagnosis of bipolar affective disorder or schizophrenia than patients with any other type of neurodegenerative disease. So it's often mistaken for psychiatric disease, especially in our behavioral variant patients. They're at the highest risk for misdiagnosis. And because psychiatric misdiagnosis can lead to delayed and inappropriate treatment and family and patient distress, that's why we really need to keep in the back of our minds and raise awareness about FTD so we can try to reduce this average time to proper diagnosis from 4 years. That's just unacceptable for these patients and their families. I will say we were really fortunate in my family that I was lucky enough to, just happened to work in geriatrics, and I had a lot of connections with a wonderful clinic here we have in Syracuse, upstate. And my mom was able to go through different diagnoses. She will talk about it, but did a PET scan, and she did neuropsych evaluations, and she had a diagnosis in under 6 months. So we were really fortunate. So FTD is sometimes misdiagnosed as Alzheimer's, mainly because of the executive function that is affected. So that's where we see the disorganization, distraction, poor planning. And of course, these patients are obviously going to be poor performers on the cognitive testing for executive function. So let's do a self-assessment question to make sure you're all still with me. When does FTD disease onset usually occur? What is the mean age? Now, this would be much more fun if we were all in the same room, but if you want to pop your answer into the chat, feel free. I'll give you just a minute and then we'll move on to the answer. And take a peek at the chat here. Yeah, okay, great. Everyone, for the most part, seems to have a good handle on it. It's in the sixth decade of life. So let's talk about genetics of FTD. So a family history of dementia or psychiatric conditions is present in about 40% of patients. but without a clear inheritance pattern. So researchers have identified 3 genes that account for the majority of mutation-associated hereditary FTD cases. This is the C9orf72, the GRN, which is a progranulin, and the MAPT, which is our microtubule-associated protein tau. These are the 3 genes that we know if a patient has a genetic mutation in any one of these 3, that they have a very, very high chance of ending up with FTD. Clinical trials for anti-tau drugs, the GRN and the C9orf72 are underway. So if you have a patient or a family member who is interested in learning more about these studies, the Association for Frontotemporal Dementia is a really great resource, and it has all of the ongoing clinical trials that are actively recruiting. So I'll share with you that I enrolled in a study and I was tested for one of the 3 genetic mutations. And so unfortunately I was negative. My next plan is I would really like to get my mom tested for all 3 and go from there. So is it inherited? It is, but the majority of the time it is sporadic. So what do we do after a patient has been on this lengthy road? They finally get the correct diagnosis. How do we manage it? Unfortunately, there are currently no effective disease-modifying treatments for FTD. Both pharmacologic and non-pharmacologic interventions are really aimed at ameliorating the symptoms. We're looking at just treating the behavior, especially behavioral variant FTD. So let's talk about the treatment for behavioral symptoms. Again, we talked about earlier how most patients with any type of dementia are at a really high risk for depression. And also we have found that in FTD patients, especially the behavioral variant, antidepressants are really what we need to start with for improving behavioral symptoms. And we have a high level of evidence for this, a randomized double-blinded placebo-controlled trial. I will say, as we're going to talk about a couple of studies going forward, we need more research on FTD. The trials I'm going to go over with you are ridiculously underpowered, and we need more patients to be involved. And we'll talk later about patients' perspective of being involved in research, which I think is interesting. We also do have some case study level of evidence for using antipsychotics, and these may improve behavioral symptoms. But if you take one thing away from this talk, other than an awareness of FTD and what it is, I would say for antipsychotics, it's really, really important that we consider risk versus benefit for every single patient. And we have to come back and reevaluate 2, 4, 6 weeks after the patient starts a therapy and make sure that that benefit is still outweighing that risk, because that's not always the case. And so I put that again here because I want to make sure that I really hammer this home. We have to weigh the pros and cons of using antipsychotics in our FTD patients. There are no evidence-based analysis to assist the clinician in making these decisions. And we always, in all things geriatrics, we start low and go slow, but especially when we're talking about antipsychotics. And we can always titrate upward as necessary and as tolerated. It's much easier to add on than it is to take away, as I tell the providers. Always start with non-pharmacological interventions. And an excellent non-pharm resource for patients and family members and caregivers and care partners is Tepa Snow. If you're not familiar with her, she is a wonderful resource for anyone with any type of dementia. And then she actually has classes that are non-pharm interventions specific to each type of dementia. So I myself took some of her classes online just to better learn how to navigate life with my mom, because it's so different now as her brain is dying. And again, we need to assess the need for an antidepressant before we start antipsychotics. I would argue that all patients, most of the time, never say always or never, right? But most of the time you want to make sure a patient is at least on an antidepressant. We've seen them on it for 8 to 10 weeks before we're trying to make any other changes. And of course, there are going to be exceptions if the patient is a risk to themselves or to others, but assess the need for an antidepressant before we start antipsychotics. So what are some non-pharmacological interventions we can do? an exercise program, modification of the home environment, increased supervision, physical therapy, occupational therapy, speech therapy, behavioral modification techniques. Redirection replaces correction and explanation. You can kind of, sometimes an easy way to think of it is like when you're talking with a toddler, you're trying to mitigate a tantrum. Redirection can be a really good tool to try. And the biggest thing with FTD, because again, in our FTD patients, these are younger patients. So primary caregiver or care partner, whichever term you prefer, support and respite is so key, because caregivers, they get burned out really easily because it is a tough, tough job. So let's talk about cognitive symptoms. And this is something else I really hope that you take away with you tonight. Acetylcholinesterase inhibitors may actually worsen behavioral symptoms. So I want to let that sink in, because it's kind of counterintuitive to, if you look at dementia with a broad view, what we usually give to help with cognitive symptoms is actually going to make their behaviors worse. And again, this is why we have to be reassessing our patients 2, 4, 6 weeks after we start a new therapy and seeing how things are going, making sure that that benefit is outweighing the risk. And for most patients, we are actually finding with FTD and acetylcholinesterase inhibitors that it's worsening their behavior. And the same thing with NMDA antagonists like memantine may actually worsen behavioral symptoms. So this is a really good intervention that you can make as a pharmacist if you see a patient with FTD. Talk with the family members, whoever is familiar with the patient, find out how long they've been on it, and trial being off of it and see how things go. It actually, the majority of the time, you will see that symptoms will improve. So to talk a little bit more about this, so the treatment for cognitive symptoms with donepezil. So Mendez et al. Studied this. They studied donepezil in a 6-month open label study. Again, only 24 patients. So these are really small studies. I will absolutely give you that. But this is where it's important to just, okay, here's some data to help support this, but I'm also going to do due diligence and find out with my patients specifically, how did they respond since they've been on this therapy? The groups didn't differ on most variables at baseline or at 6 months. However, the donepezil group had greater worsening on the FTD inventory. Discontinuation of donepezil resulted in abatement of behavioral symptoms. So that's good news, that at least it is reversible if we're able to get our patients off of this. And there was no changes in the global cognitive performance or dementia severity. However, a subgroup of patients with FTD can experience worsening of symptoms with donepezil. So again, just some data to help support that recommendation to get patients off of donepezil if they have FTD. Memantine and FTD. So this was another study that from Boxer et al. That looked at determining if memantine is effective in treating patients with FTD. So again, it's a small study. We had 42 patients in the placebo group and 39 in the memantine group. And this is with patients that were diagnosed with FTD, receiving 10 milligrams of memantine twice daily for 26 weeks or placebo. And this was titrated from 5 milligrams daily to 10. You'll see that the change in the NPI, the neuropsychiatric inventory score, and the clinical global impression of change was not significant. Now, this study did have some limitations with recall bias and possible poor internal validity due to different healthcare providers using the CGIC. However, it's important to note that it just wasn't helpful for our patients. So to consider getting off of it. So how about our patients who have movement symptoms? We can use dopamine replacements. It's a pretty low level of evidence case series. However, there was modest to no benefit. So again, just looking at risk versus benefit for each patient and reassessing once they've been on it. So let's do a self-assessment question and make sure we're all on the same page together. FTD can cause a decline in touch sensation, vision, hearing, or ability to manage finances. You can go ahead and put your answers in the chat. Okay. Let's go to the next slide here. And the answer is D. See how we did in the chat. Yeah, looks like everyone is on the same page. It's a great job, everybody. So let's talk about a patient case. We'll start with Frank. He's a 65-year-old male with a past medical history of a CVA in the left cerebellum, hyperlipidemia, and insomnia. He comes in for evaluation of new onset behavioral issues. So, sounds familiar from what we've been talking about tonight. His partner reports that for the last 2 years, he has not been himself. He lashes out easily. He developed some new obsessions with cleanliness, organization, and eating sweets. Remember that, eating sweets. He has been touching or kissing strangers and urinating in public without concern. So not able to pick up on social cues and what is and is not appropriate. Makes offensive remarks in inappropriate contexts. However, otherwise, he is independent functionally. So let's take a look at his medication list. He's on donepezil for dementia and memantine, pantoprazole, and acetaminophen. So what recommendations would I make if I were to see Frank in our geriatric clinic? First, non-pharm interventions. Keep him on a daily routine is really, really, really important and actually can help a lot to mitigate some of the behavioral issues. Engage the patient in sensory stimulation, music therapy. There is a wonderful movie on Netflix about music therapy with dementia patients, specifically Alzheimer's, but music therapy is wonderful in any type of dementia. It was by a social worker. At the end, I'll look up the name of it. If anybody's curious, you can put it in the chat if you know, if you're familiar with this movie. But anyways, music therapy is wonderful in dementia. Animal therapy, daily physical therapy, and cognitive exercises. The care partner, caregiver should develop a care team and respite plans. As soon as we're diagnosing patients, we need to help give them the support to develop that care team because it takes a team, and we need to have respite plans in place with a planned respite for that caregiver. Discontinue donepezil and memantine because it probably is making Frank's behaviors worse and it wasn't helping with his cognition. Then I would start trazodone 25 milligrams at bedtime. And the reason why I'm going to start with trazodone is because he's having insomnia, and I suspect that if we can improve his sleep, that things will get better from there with all the other non-pharm interventions. I would also consider starting sertraline or citalopram at a future visit, but I only like to start one medication at a time and then check in with the patient every couple of weeks to see how we're doing. So when I talked about creating a care team for Frank and his caregiver, I'm talking about this multidisciplinary team. So we need a lot of people on board. We want a PCP, neurologist, even a neuropsychologist is also a really beneficial person to join the team, especially while we're going through the diagnosis journey. A pharmacist, a psychiatrist, geriatrician, movement disorder specialist, speech and language pathologist, PT, OT, psychologist, and a social worker is also really, really key members of the team, or a case manager. Counseling points for the caregiver or care partner. So adult day services, a pharmacist to review the meds. These documents are really, really, really important. I'm fortunate that we were able to get my mom's squared away right before she went into assisted living. We were fortunate that our lawyer came over and did it right at my house. But healthcare proxy, power of attorney, and advanced medical directives. And just for anybody out there who's listening tonight, it's important to have these conversations and these documents even now. So especially if you have kids, you want to have all of this situated. And, you know, you never think you'll have dementia in your 60s, but you want to make sure all of these things are settled and your family is all aware of what your wishes are should something happen. In-home services, And this is something I found through the experience with my mom, but you want to make sure that whoever is coming in to help take care of your loved one or a patient with FTD, they need to be trained in FTD. People hear dementia and most people think Alzheimer's, but there are, obviously after tonight from your listening to this, you know, there are so many types of dementia, and FTD is really unique, and how we approach the patient needs to be fitting for that. So as I mentioned earlier, this is it in text, so you can see the spelling of her name. Teppa Snow is an excellent source. FTD support groups are wonderful, and keeping a diary, because it's important to be able to track the changes between office visits, because as with any neurodegenerative disease, it's always a moving target. So it's the best way to keep track of where we're at in the progression of the disease is a diary. To talk about the progression of the disease a little more, my husband actually was able to really pinpoint my mom's symptoms, and it got to the point he was able to predict where we were in her spiral based on how she was acting. So when she would really start rhyming her words and not making sense, it's when things were really about to truly get worse, and we needed to change her meds around a little bit. So this is the new section for those that were at the ASCP annual meeting that I'm really excited to share with you tonight. This was released a little bit later than the deadline, so I wasn't able to present on it in San Diego, but tonight I'm excited to share with you. So on March 5th of 2021, people living with an FTD diagnosis, care partners, and caregivers participated in an externally led patient-focused drug development meeting to describe their experiences with the FTD disorders. So I was on this call. I didn't add anything to it, but it was really interesting to learn from and to be a part of. Due to the COVID-19 pandemic, the meeting was held virtually, but this format allowed increased participation by individuals from all regions of the United States, as well as people living in other parts of the world and people who would normally not have been able to travel to an in-person meeting. So the whole purpose of this was designed to help FDA regulators understand the experiences and priorities of people living with diseases such as FTD disorders. And I found a lot of the questions I was asked when I gave this presentation before are actually answered in this report. So I wanted to go through some of them and share some of the quotes from the report with you. It's really interesting. It's like a 75-page report if you want to read more into it. So there were 5 key themes that they were looking at in the executive summary. So they were looking at the devastating impact of FTD symptoms. They assessed difficulty obtaining reliable FTD diagnoses, as we talked about earlier, where misdiagnosis and that journey to the proper diagnosis of on average being 4 years. The impact of familial FTD for those that do have the genetic mutation in their family, lack of effective treatment for FTD, and patient and family members' perspective on research participation. So let's get into this a little bit. Are FTD patients aware of their symptoms? So you'll see we have it separated into behavioral variant, FTD on the left, again, being the most common variant of FTD, and all the other ones combined on the right. So for behavioral variant, only 8% of patients actually have the insight to realize that with their symptoms. 15% would say mostly, but 30% say not at all. I think that's really interesting. I would say my mom, if I had to say, she would probably go into the mostly category. There were times when she was having a lot of falls, like, 15 in 1 month, like almost every other day. I was getting a call from the nursing home that she had fallen, and she would say that she felt like her feet were out of control and they were walking so fast and she couldn't stop them. So again, that as the brain is dying, it's not connecting how to properly walk. So health effects and daily impacts. So these are some quotes that I just thought gave some really valuable insight for everybody about what it is like. So we had a gal who was a caller. A gal was a caller from Florida and a former caregiver to her husband. He had the behavioral variant. So she wrote, he was diagnosed at 50, though his symptoms started in his 40s. It took us 7 years to get a diagnosis, which was really sad. And when you think about it, somebody who started their symptoms in their 40s, typically those are your prime financial earning years. So this disease can really be financially catastrophic for many families. Some people, I mean, in their 40s still have young children at home, in the home, and that can actually cause people to have to move their loved one into a facility because it's not safe for the children to be around. This one from Dawn from Illinois, who cares for her daughter. She was diagnosed at the age of 29, but the actual symptoms began at 27. We didn't actually realize because she was diagnosed with postpartum depression and then psychosis. Due to her young age, it was not on their radar that she could have dementia. So that was one that really stood out to me. It's like, wow, she was so young. Aisha from Georgia wrote, diagnosis took a couple of years and ranged from generic stress to menopause-related anxiety and depression, during which time her symptoms remained untreated and continued to become more extreme. And then I thought that this quote from Dan, who was diagnosed with behavioral variant in 2019, kind of shares a little bit about the journey to diagnosis. PET scans, MRIs, labs, and spinal tap confirmed sporadic behavioral variant, frontotemporal dementia diagnosis. Treatment, none. Prognosis, fatal. Symptoms, progressive. That really just encapsulates FTD. First indication of something being wrong, and this is reported by persons diagnosed and caregivers in the FTD Insights survey. So you'll see that with the behavioral variant, personality, which makes sense, right? When we think about what are the symptoms of behavioral variant. For PPA, primary progressive aphasia, again, that's our language. That makes sense too, that language was the first thing that was noticed. And a patient, Jennifer from Alabama, noted how her PPA language symptoms have worsened. Sometimes when I try to speak, nothing comes out. Sometimes it's guttural sounds that come out or nothing at all. Even when the words are in my mind, I can't get them to come out of my mouth. Sometimes it feels as if my mind is buffering, which I think is a really interesting insight into how frustrating that must be for people. And of course, you can understand how over time, that is so hard for the patient. And then you have behavioral going along with that. And as the caregiver, it's got to be so frustrating as well to feel so helpless to see your loved one going through that. So this is a past use of prescription medications as reported in the FTD Insights survey. So current and future approaches to treatment. So we see that most patients have been on an antidepressant, which is appropriate, right? That's our hallmark. We want to start with an antidepressant, wait 8 to 10 weeks, see how the patient's doing. Unfortunately, we also see getting pretty close to that 50% line is cognition enhancing drugs, which we talked a bit about how probably is just going to worsen the behavior and not actually help with cognition. Then we see, understandably, some use of antipsychotics and anxiolytics and mood stabilizers. And for cognition enhancing drugs, I really just wanted to put this in there again. So it was a big takeaway for everybody is that nearly half of FTD Insights survey respondents indicated that they or their loved one had been prescribed cognition enhancing drugs despite evidence to contraindicate their use, including lack of benefit and evidence that they exacerbate behavioral symptoms of the FTD disorders. So you can leave this talk tonight remembering you see a patient with FTD, with a proper diagnosis of FTD, we need to look at if they're on a cognition enhancing drug and try going off of it and see how they do. So current and future approaches to treatment. So Dorian described the desperate and painful journey of changing from one ineffective medication to another. So meds offered short-lived and fluctuating relief, and we were constantly adjusting the doses every 3 months or less. All were imperfect tools, but the only tools we had, none impacting the underlying pathology. None of the medications Matthew was prescribed ever managed his impulse control. And that is what is so frustrating with this this debilitating neurodegenerative disease. It's always a moving target. And so we are constantly looking at the medications again and seeing how we're doing and what do we need to change. And I would say that about every 3 months sounds, similar in my situation as well with my mom. So this other quote was from Halima, who's a geriatrician. And she spoke about her father who has PPA, so primary progressive aphasia. When thinking about drawbacks of our current treatment approaches, side effects, I think, is the biggest. Also, number of pills, as well as questions of effectiveness. So, especially in primary progressive aphasia, we can see patients eventually have difficulty swallowing. So pill burden is a really big deal. I don't think I mentioned this earlier, but the most common cause of death that we see in our patients with FTD, regardless of subvariant, is pneumonia. Now, Brandon from California became a primary caregiver for his mother when he was 19, which is really sad, so young. A VCP genetic variant runs in his family. Her symptoms have constantly been progressing and changing, and so we've constantly been evaluating the medications that she's been taking, making adjustments to her dosages. It's a constant struggle to gauge the benefit of an antipsychotic or a mood stabilizer or a sleep medication with the negative effects that it has at the same time. So that is why we have a pharmacist on the team to help with this moving target. How well does the current regimen control the symptoms? The overwhelming majority are going to say somewhat to very little. And unfortunately, we just need new treatments for these patients. And we're going to talk about where is research and what are they working on now, and how can we help with that? So just a couple more quotes. I won't go through all of these. You're welcome to review them in the slides when they get released. But let's see here. Hannah, a police officer from the UK, illustrated the amplified trauma of genetic FTD. With my dad's diagnosis came another blow. It was genetic. I debated over having the test, but I realized that I could live better with the result, whatever it was. Then I was given the bad news. I am to suffer the same fate as my dad, giving my children a 50% chance too. I look at my children every day as they run and play with their friends, knowing that I'm responsible for this brutal condition potentially affecting them, and that kills me. So whether or not patients and their family members choose to have genetic testing is a deeply personal decision that they have to speak with a genetic counselor at length for good reason. And it can really affect big life decisions. If you have not already had children, do you decide to not have children because you are positive? These are really big decisions. I can share with you, for me, when I was making the decision whether or not to enroll in the study and get tested, my husband and I spoke about it at length. And we ultimately did decide that, although we'd already had a child at that time, we wanted to know, because I think for me, it would just change my financial picture. Like, I would probably invest less in retirement, and I would probably retire earlier as well. So, for everybody, it's a personal decision and it's a tough one. Willingness to participate in research. Overwhelmingly, persons diagnosed are very willing, 63%. And at-risk relatives, 40% are very willing and 37% are willing. So, the patients and the family members, we want to be a part of the research. We want to at least help future generations from not having the same terrible fate that our loved ones and some of us will have. So a plea to the clinical researchers. This will be the last quote I'll share with you guys tonight. Frontotemporal dementia is the cruelest, most unrelenting disease that completely strips its victims of their identity and robs families of a piece of their soul. We need relief, and it cannot come soon enough. And this was the final quote that they actually shared with the FDA in the report, and I feel like it was really impactful. So I wanted to share that with you guys too. So in our last 14 minutes here, I'm going to share a little bit of my mom's journey. So this is my mom, Sue. She is the best mom. It's my older brother and myself, it's my mom and dad on the left. And she just loved being a mom. I can't tell you how often I was asked what what her hobbies were. And like her favorite thing in life was being a mom. She would be the mom who's up at 5 a.m. to cook cookies for like the bake sale at school the next day. So but we'll talk a little bit more about how important it is to have hobbies outside of being a mom, because when you get older, you really need some hobbies. So in November of 2019, my mom had increased anxiety and depression, interfering with her ability to work. And to be very honest, about every decade of my mom's life, for as long as I was alive, she would have these bouts of just crippling depression where she would have to be hospitalized and kind of get her meds sorted out. And then she'd be, back to her great baseline self. So at first, we just kind of thought that this is what this was. We were just, okay, it's been about a decade. So, had her primary care take her out on FMLA. And we just thought it was depression. So my husband and I had a brilliant idea, let's go to Aruba. We'll take my parents on this trip. And because, January in upstate New York, it's pretty cold and there's not a lot of sunshine. So we thought that Aruba would be a great idea. But this trip is what changed my perspective, that this was not depression and it was something much, much more. I saw firsthand that she was impulsive. She was taking more medications than she should have. They got to the point that I had to keep her pill box in my luggage in Aruba, and she still tried to go through my luggage to get to them, which is just so not her if she had all of her faculties. And she was also really overwhelmed for someone who loved to be a mom. I mean, she was tenfold in love being a grandma. That's my oldest there. That's Mason on the left. That's my other little guy, Tater, my dog. But she couldn't sit with my 9-month-old son. She was like, why do you keep leaving me with him? But even if I was just across the room. So to me, that was a big red flag that something is not right. This just isn't her. And even as I look at this picture of my mom, like I can tell that she looked like she had a lot going on behind that smile in her mind. So in June 11th of 2020, she had confirmed on PET scan, checking all the boxes for behavioral variant. She was 64 years young at the time. She was impulsive. She would come over to my house and she would want to get in my hot tub and she would just get in fully clothed. And she would swear a lot, which was also very much not her at her baseline. To the point she was acting like a child. I saw a lot of similarities between her and my toddler. She eventually struggled to use a cell phone. So she would send text messages to friends and family that were just letters. It was just garbled. It didn't make any sense. She used to be the primary executor of all things in my parents' life. And she could no longer handle finances. And she became combative. And it was mostly towards my dad. My dad is the kind of guy who's, he's very tight-lipped. So I think even to this day that I won't ever fully know what he went through because I don't think he shared a lot of it. But I remember in Aruba when she lashed out to hit me when she was uncomfortable, my dad's like, oh yeah, like she does it all the time at home. Dad, why didn't you share that with me? So that can also be a challenge. That was a challenge. So my mom had a really rapid progression of her symptoms about, 1.5 to 2 years ago now. She was helping with my son, with her newborn grandson. She was, helping do the overnights because he was such a colicky, cranky baby for his first 2 months. And then fast forward, just 1.5 years later, and she couldn't work, and we had put her actually in a day program for people with dementia, and she was asked to leave, because she was scaring other patients. And, it blew my mind. There was at one point I was researching daycares for my mom and my son at the same time. And we put her into assisted living. She was kicked out after 1 week of assisted living. I also think they didn't totally give her a fair shake because she had a UTI. So as you know, anybody with any type of dementia that has UTI only exacerbates behavioral symptoms, but especially in a behavioral variant patient, it's not a good combination. We had FTD trained aides who were trained in the Tempo-Snow method coming into the home for more than 40 hours a week. And even with that assistance, it was just too much to handle for my dad. And unfortunately, with me having 2 little ones at home, it wasn't really an option for her to move in with me. So we moved her into a SNF, and she's actually doing really well there. And here I have no longer walking. She wasn't walking for a long time, especially after she was having all those falls. They actually didn't want her to walk. They put her in a scooch wheelchair. But I get to visit her weekly now, and she will take her a walker and walk to the bathroom with an aid. So she can walk a little bit, but she's definitely losing her ability to walk. Her memory is preserved for now to a certain extent. She knows who I am. She knows my boys are her grandsons, but she doesn't remember their names. And so this is actually her with my oldest Mason, and his name is her maiden name. So I'm surprised that she doesn't remember that name, but she has a lot of hallucinations. She has a lot of hallucinations with, conversations and people that don't exist. And this can become problematic when the hallucinations are upsetting to her, because then she tries to get out of her wheelchair and she falls. Sometimes her hallucinations are wonderful. Oftentimes she thinks she's in nursing school and the nursing home is a dorm. So, sometimes it's okay and sometimes they're not great. So the first thing I do, though, when she's having hallucinations is we look at the antidepressant and maximizing that dose. Oops, sorry. I can go back one. There we go. Okay. A lot of lessons learned in my very intense journey of, drinking from a fire hose in the past 2 years with my mom going through this. But the toll on the primary caregiver care partner was greater than I think I'll ever truly understand for my dad. Denial is very prevalent. And I would have watched for lack of engagement with information on FTD. And also to keep in mind that grief is recurring and it can exacerbate depression. Encouraging therapy and support groups is really helpful for the caregiver, and encourage taking time for our own hobbies. And also letting hired help provide solo care. That was something that my dad just really felt. My parents have been married for almost 40 years now. So my dad really felt so responsible for my mom that even when we had these specially trained Snow aides coming in the house, he didn't feel like he could leave her alone with them, because what if she acted out or what if she tried to hit them? He just really felt like he needed to be there. And I would have to, on my day off, I would literally go over there and bring him with me to go grocery shopping or any errand I had to do, just to force him to get out of the house and let the hired help provide solo care. And even then, he would still be very anxious after an hour or two to want to get back. So he never really got to get away and feel restored. And, you can't pour from an empty cup, as I always say. So doing those types of things to really put the emphasis on the caregiver, which is really, really challenging when you're, handling everything at once and trying to put together this care team, and your focus can very easily become obviously on the person with FTD, but trying to also keep it on the primary caregiver, I think, is a lesson that I learned. Another lesson I learned the hard way is educating the caregiver or care partner on scams. When you think about it, so in the case of my dad, or as many family members who become the primary caregiver for an FTD patient, a lot of them are forced to retire early. So, my dad went into work on a Thursday. When my mom was discharged from the hospital and we figured out the diagnosis, they were like, she needs 24/7 care and you need to retire tomorrow. And as of Monday, you're retired. So this was really hard because my dad, and then, fast forward a little bit, and my mom's in a nursing home. He has all this time on his hands. And he's lonely. And there are so many scammers out there who are just waiting to jump on that. So in my dad's case, it was through Facebook. But there are things you can do. So I have bought identity theft protection services. You can put a credit freeze on yourself or on your loved one, so that credit cards cannot be opened, even if the person has their social. You can actually go into your bank and give them a verbal password, so that if somebody were to have your account number without that verbal password, they can't actually do anything with it. And you can lower credit card limits to try to mitigate the amount of damage that can be done if credit cards are given out. Help develop hobbies if they don't already have one. Hobbies are so important. even as myself as a mom, there's 2 little ones, I still really try to make time to do my own thing too, because when you get older, it's really, really important to be able to have those hobbies to draw on to help, make your older years enjoyable, whether you have dementia or not, whether or not you're a caregiver. So in conclusion, FTD is symptomatically complex. The symptoms come from the anatomy, so where in the brain the atrophy is first presenting. FTD is pathologically and genetically complex. There are multiple pathologies. We have 3 known genetic mutations. They overlap with other syndromes, and diagnosis needs to be multimodal. Proper clinical characterization and imaging with the PET scans. Our current treatments are limited, and we're really just treating symptoms, especially in the behavioral variant case. Future treatments will be aimed at specific proteinopathies for patients with genetic mutations. So patients who have sporadic, which I am hopeful my mom's in that category, they aren't even right now, we don't have anything in the works. So right now we're just really looking at if we can do genetic testing and find out which marker is mutated, and we can go from there. And that's also where there's benefit. If family members are willing to get genetic tested, then those would be the people who'd be involved in the studies with the new drugs as they come out. So I wanted to just provide this for you as a resource for healthcare providers. This came from the Association for Frontotemporal Dementia. Again, this is just for your reference if you choose to review these slides once they're posted on NYSCHP site. And this is resources for families. And you actually can order these for free through AFTD, and we have this one in the clinic at Upstate. The doctor thinks it's FTD, now what? So these are just some really nice resources that can be helpful. And AFTD for kids and teens, because as we know, this is a dementia that affects the younger people. So a lot of people have young kids at home. So books that kind of help them understand what's going on with their loved one is helpful. And that's all I have. These are my references. We have a couple minutes to spare. So thanks for hanging in there. I know it's a late night. Do you guys have any questions? I'd be happy to answer any if I can.
So thank you so much, Dr. Ulen. I do have one question that came in the chat, and it is the sense of smell impacted?
It is not. That was a distractor. Well, thank you for listening, everyone.
Thank you so much. At this time, I want to thank